Hello, I'm Terry Clearwaters. I'm the Divisional Educator for Respiratory Care Services at Tampa General Hospital. The purpose of this video workshop today is to give an overview and educate on mechanical ventilator modes as they affect the lung, and for demonstrations we have it attached to a pig lung. And so you've already had your lecture from Dr. Jennifer Cox on the PowerPoint presentation on mechanical ventilation. So the purpose of this is to try to demonstrate and put that in your adult learning mind of how those different modes and that mechanical ventilator actually affects the human lung, and we're trying to demonstrate that today in a pig lung. So we're going to demonstrate different modes. Our goal for you today is for you to understand that one of the main things as a physician managing a critical care patient, you have to work with the critical care team, and you have to work with your RNs and your RTs, because one of your big goals as a physician is to make sure that the patient is able to be ventilated and oxygenated. And your goal, that you have to meet is to make that patient comfortable on that mechanical ventilator with an endotracheal tube, and that involves utilizing pain medicines and sedation.
Hi, my name is Nick Bruno. I'm one of the UBs for night shift on a respiratory. I'm going to be going over the Servo U vent. Peach Dixon is assisting me on camera. Okay, so first things first, we're going to show you how to change the modes. So you go here to modes, and it's going to give you different options. Control modes, interactive modes, and support modes. In the control modes, which we'll go over first, we're going over volume modes and pressure modes. So when we're talking about volume modes, we're talking about volume control and PRVC. When we're talking about pressure modes, we're talking about pressure control and BiVent, APRV. So we'll start right now with volume control mode. Now when we're in this mode, we're setting a target volume, a tidal volume for the patient, and every breath that they take will be that target volume, tidal volume, hopefully. And now, if you're trying to manipulate ventilation in this mode, you want to manipulate your respiratory rate or your tidal volume. If you're looking to manipulate or to affect the patient's oxygenation, you want to go after the FiO2 or the PEEP. Now, the only difference between this mode here, we'll go ahead into this mode now, so you can see it on the pig lung. Okay, so we're in volume control now. The only difference between volume control and PRVC, pressure regulated volume control, is that in pressure regulated volume control, we're targeting the volume, but the machine is auto setting the pressure to meet that volume. Okay, so now here we have the lungs on volume control. Now the only difference between volume control and PRVC, pressure regulated volume control, is that in PRVC we're targeting a tidal volume and not mandating that tidal volume. So let me explain. Essentially what we do is we target a volume, let's say 450, and the machine will set the pressure in order to reach that volume. So if it doesn't quite reach that volume on the first breath, it will increase the pressure until it meets that breath. If it overshoots the volume, it will decrease the pressure automatically in order to meet that breath. Okay, so we're going to switch now to pressure control. Now, with pressure control, we're setting the pressure on that mode, and every breath that the patient will take will be that pressure. So, for example, right now I have the pig lungs on pressure control of 12/8. So that's a peak pressure of 20. Every breath that these lungs take will be a pressure control of 12 over a PEEP of 8. And based on that and the I time, we'll get a exhale tidal volume, but that will not be in any way set, or it'll be a received value. Now, when we're talking about pressure control, and we're looking at ventilation versus oxygenation on that, again, respiratory rate will be used for ventilation, and also the pressure control. Depending on how much pressure you give, will determine how much volume you're getting from the patient, and that'll help your ventilation. But likewise, with the volume control mode, we'll look at FiO2 and PEEP for oxygenation purposes. Now, the next mode we're going to go into for pressure will be APRV, but we will come back to that. In the meantime, we're going to go over spontaneous breathing modes. Now, when we look at the spontaneous breathing modes, SIMV in any mode, whether it be pressure control, PRVC, or volume control, when it's an SIMV of those modes, it is a little slightly bit different. Earlier when I was saying volume control, every breath that the patient takes is mandated that set tidal volume, or with pressure control, mandated that set pressure control. With spontaneous, with SIMV, we have a set rate that that patient is breathing, that set value, whether it be volume or pressure. However, any additional breath that the patient takes after that will be supported by a pressure support, and we'll set that value usually like a 10 or an 8, and that the patient will breathe, will trigger the breath and get that support, but it will not be necessarily what is mandated on the mandatory breaths. Okay, so here let's look at SIMV a little bit closer. Now, as I was stating before, we have a rate set at 10 and a tidal volume set at 400. So when the patient breathes, 10 of those breaths will be mandatory, 400 tidal volume like this one. However, the patient is breathing over the vent currently. We're looking at 19. So these smaller breaths are pressure supported breaths, and you can see where the white shows where the patient has triggered the breath, right? And you'll see down here on the volume waveform, these are 400, give or take, but these smaller volumes are based off the pressure support breath and are much smaller. For example, 242 versus what we're mandating. Staying on SIMV, as we look at the pig lung, you can tell the difference when the patient is getting a pressure supported breath and a mandatory breath. This is about tidal volume of 400, and these are the pressure supported breaths. So you see that there's less expansion on the SIMV breaths. However, that does allow for the patient to give more effort on their own. Okay, the final pressure mode we're going to go over is APRV. It is quite a bit different from the other modes. Now, APRV you're going to use more when you need to achieve better oxygenation with the patient. This mode typically will allow for some permissive hypercapnia. The idea of the mode is to keep the lungs inflated as much as possible. You're going to have high pressures for long periods of time with a short drop to get rid of your CO2. So for an example of settings that I've set here, you're going to be at a high pressure of 18 for 4 seconds, and then a low pressure, a PEEP of 2 for 0.8 seconds. Sometimes you can have that PEEP be actually 0, because the idea is the patient will never actually fully reach 0. The time is too short, and it's just enough to get rid of some of the CO2 there. So we'll see this in action here. Go back up. So what you'll see here, let me silence that. So what you will see here is long, drawn-out tidal volumes with a short drop. And what this will do is, like I said before, and what will show in the lungs is that it will increase the mean airway pressure in the lungs for a longer amount of time with that short drop to get rid of your CO2. Now, when you're in this mode, your settings to control your oxygenation, FiO2 obviously, but also your high pressure is actually where you want to go, because you're looking to increase that mean airway pressure. The PEEP is actually not necessarily what you're looking for oxygenation. A lower PEEP will get you more ventilation because you're getting rid of more CO2. A shorter I time will help your oxygenation because you're staying in that high pressure longer. However, if you have the shorter the I time, the less CO2 you're dropping out. Now now you can see here on the pig lungs, we're still on APRV, and you get really good lung expansion on the pig lung here with the APRV. Short drop to get rid of CO2 to ventilate. However, you're staying with high pressures for a long time, which will really recruit as much alveoli as possible. And you should see a difference between this mode and some of the other modes we did before. Okay, final thing I want to touch on in APRV mode. Unlike other modes where you can set the rate here is set by your I times, your times that you've set. So I have a T high and a T low. When you add those together, that's your total ventilation time, total cycle. And that necessarily how much time you have on your total cycle is how much time you'll have in a minute. So, and the ServoU will actually calculate this for you. I set a high time of 4 and a low time of 0.8, and it tells me that my respiratory rate is essentially 13. And if you see right here below the 13, it says I to E 5 to 1, which is essentially what APRV is. It's essentially inverse ratio ventilation with much more pressure. You can do this kind of ventilation in volume control. However, it's a lot more effective to do it, and you can do much more extreme I to E ratios in APRV. Okay, briefly I want to go over when we have a patient that is intubated and being mechanically ventilated, we're going to monitor a couple things. So obviously they're going to be on a continuous monitor. We're going to be looking at heart rate, blood pressure, SATs, respiratory rate, etc. Typically, a daily ABG will be done just to see where they're at, and more often if necessary. End-tidal CO2 is an option, typically done in ER and some of the neuro floors, but is an option certainly on this vent and some of our monitors. We can do X-rays, a lot of daily X-rays on intubated patients. Look at electrolytes, and finally, if we need a diagnostic tool for the lungs. And we've expended all our others, we can do a bronchoscopy to see about excess secretions. We'll discuss weaning and weaning modes now. As I start to do that, let me first mention that SIMV can be used as a weaning tool when it's set at a low rate. So if you have a low rate set, just enough as a backup, the patient will, like I said before, our mandatory breaths are much less, so the patient is ending up having to do a lot more work, and therefore it's effective as a weaning parameter. Okay, so but the other weaning modes used are pressure support, CPAP, and volume support. So let's go into pressure support now. When you're setting pressure support, so the idea is that there is no rate on either pressure support, CPAP, or on volume support. No rate set, but there is a backup rate. So let's first go over the settings. You're going to have your FiO2 like normal, PEEP, and a pressure support set. So when the patient triggers a breath, they will get that pressure support breath, and then they'll go back to their PEEP. Now, if the patient does not trigger breaths within 20 seconds, the apnea time right now is set to 20 seconds, it will shift into a backup mode. Typically, this is pressure control, and we have a set rate and pressure control just in case that happens. That patient goes apneic, we have some way to ventilate them, right? So we're in this mode now. It's going a bit fast here, and so you can see when the lung comes up here or any of these white lines, these are the breaths that the lungs are triggering. Okay, so right now we're demonstrating the lungs on volume support. I'm going to switch it here briefly, and we're going to go back to pressure support so you can see that on the lungs. Okay, now we're on pressure support. It's taking a minute to trigger here. There we go. Now these are the lungs on pressure support weaning. All right, so let's discuss weaning a little bit more. When we're weaning, typically we'll put them on an SBT, a spontaneous breathing trial. The doctor will work with the critical care team, the RN and the RT, will work on weaning sedation, and the patient will then be put on the SBT by the RT. Now, one option for that is to put them on a T-piece, providing flow and oxygen and allowing the patient to spontaneously breathe on their own. Another option for SBT is, as we stated before, pressure support and volume support options. Now, when the patient does that, the RT will put the patient on the vent, either pressure support or volume support, for at least 30 minutes. At that point, we'll get weaning parameters. What I mean by weaning parameters is a respiratory rate of less than 35, tidal volume of 300 or more, around that range, while a vital capacity of 15 to 20 mLs per kilogram, a NIF of greater than -20, I mean to say more negative than -20, and an RSBI of less than 100. Now, if the patient does meet these weaning parameters, at that point, the RT will collect a blood gas, and all that information can be passed on to the doctor at that time, and the order can be given to extubate. Okay, and then if the patient cannot be successfully extubated at that time, it may indicate the need for a trach. And if the patient is on a trach, another option for weaning is to put them on a trach collar and allow them to wean that way. And that's all I have. I want to thank you so much for listening to my presentation. Have a good day.